Okay, so I'm gonna welcome everybody quickly as we have reestablished over the past couple of months the uh, renal biopsy rounds. And so we have this as a very clinically oriented seminar where clinicians can kind of gather, discuss cases. They will request cases through me, and then we can get the materials together to present. And the particular case that we're going to discuss today was actually biopsied and sent to our colleagues in Europe. So Sylvia will be doing the driving of the screen. So Dr. Benali, who is a close friend of mine. I do want to emphasize to all the people that are here that we actually work very closely with the EBRPS. There's a lot of times where we'll send consults back and forth about cases that are a little strange. So we are really good friends with them. So make sure if you guys are presenting cases or would like a case to be discussed, we would be happy to do this type of setup, which is what we're doing today. You can't see my face today because I'm using my desktop. So don't have a camera. We we'll be able to share the microscope screen. As you can see, there's already a slide up here. And then we try to do maybe 2 cases a day. It does seem like we often only get through 1, 2 cases each month or whatever. So we always have, a list of kind of backlog ones of cases that are just interesting. So feel free to always request a case that you think is interesting as well, and we'll make sure we are able to go through it. So today's case is, and actually, how could you introduce yourself? Because I don't want to mispronounce the name. I'm going to unmute you. I muted you just because I heard a little bit of background, but if you can, oh yeah, you're unmuted now. Okay, cool.
So hi, my name is Hila. I'm from the Koret School of Veterinary Medicine in Israel. I just finished my residency in internal medicine, and this was not a case actually that I was managing, but just one of our colleagues did, and we don't get to do a lot of biopsies, and unfortunately this is just hard for us to send them, but in this case we managed to do that. So and it was kind of interesting, so I thought it would be nice to share.
That's great. Okay, so if you, do you want me to put up the report? I can share my screen where you can see the clinical data, or do you, it's not too much that they provided, but I can share my screen to show that stuff if you would like me to.
Sure, and then I can add whatever information is needed.
So Sylvia, it's going to take it away from you for a moment, and I'm going to share it to the report, okay?
Yeah, sure.
Oops, this one, okay. Okay, so do you guys see a copy of a report?
Yep.
Okay. I'll just blow it up just a little bit so you guys can see. Okay, so this is pretty much, and I guess I should say, Sylvia, can you speak to, is this very similar to the type of information you get from your clients, or do you get more information than this?
It depends. It's not, sometimes we have less, sometimes we have more. It's not, this is, I think, something normal.
Okay, okay. So if you have any more clinical data you would like to add.
Yeah, so as you can see, she's 2.5 years old, female spayed, Saluki mix, and she first presented to us about 7 months before we took the biopsy. She had some chronic vomiting and reduced appetite, and she was losing weight, and then she was actually diagnosed with PLN at the referring veterinarian, and then she was sent for a consult due to the protein losing nephropathy at our hospital, and she had quite a lot of workup done. You can see there they ruled out Leishmania and Ehrlichia and Babesia and like every infectious agent we can possibly rule out. And we did an ultrasound. The ultrasound showed some chronic changes like in the kidneys. And I remember the cortexes were very echogenic. What else? And she also had this chronic vomiting. So, and besides her hypoalbuminemia, she also had low total protein. So she was also thought to have some type of protein losing enteropathy as well. And at the same time, she came in for the kidney biopsies. She also had GI biopsies and actually was diagnosed with lymphocytic plasmacytic IBD as well. I guess this is most of the clinical information.
Awesome. Okay, I'm gonna minimize this and then I'm gonna stop sharing. So, let's see. And then I think you can be able to share your screen back, Sylvia. And I have a quick question. Do you know, and Sylvia might know the answer to this, were the intestines sent to you guys too, Sylvia, or were they sent somewhere else?
The tests,
No,
go ahead.
No, they were sent to a local pathologist in Israel.
Okay.
So hello, everybody.
Yeah, I'm gonna mute myself so there's no echo or anything. Okay.
I'm trying to do this, is probably the second time, so let me know if you have trouble in following the slide. Here we have a PAS stains. We have true cut biopsies and small fragments, but I think that in this bigger core we have all the lesions that we need to evaluate, just because it's just simple to stay on this except of rounding around. So you see there are many glomeruli. Just a very quick look on the sample that don't really look very healthy. There are many empty glomeruli and glomeruli in which there is an expansion of the. Do you see my arrow also?
Yes, we can see your arrow. Yep.
Okay. There's also areas in which there is expansion of the urinary space and variable compression and atrophy of the tuft. Like this one. I don't know how to remove this. Let's see if, okay, maybe this works. Okay, so a very prominent lesion that we see in this case is glomerular lipidosis. Sorry, I have to do that. It's very prominent. It's from segmental, sometimes globally involving the glomerulus with these foamy cells that expands the mesangium and alter the entire glomerular tuft architecture. But in the areas that are preserved, you see that the membrane are thin, the capillary loops are well open. There is generally one or sometimes two intraluminar nuclei, so endothelial cells, so we have no signs of hypercellularity. We have this mesangial hypercellularity that gives sometimes also a lobulated appearance associated with the, of course, lipidosis. We have also, just let me look at the other important lesions that we have in this case. We have areas of adhesion of the tuft to the Bowman's capsule with variable degree of sclerosis, so what we call synechia, and areas of nodular expansion with these very PAS-positive material consistent with ialinosis or plasma insudation. Sorry again. this. And Rachel, feel free to interrupt me, or if you think there's something to be noticed that maybe I'm missing.
No, I completely I'm following everything you're saying. I think that sometimes when we see the lipid inside the foam cells or the foamy cells, whatever their lineage might be, you can see there's sometimes like some PS positive material. And
Yeah.
On the H&E, usually you can see it almost looks like ceroid or something like that. So I think there's an admix of lipid, and I think that some of that material ends up kind of being like the ceroid or lipofuscin or whatever. That's my interpretation of what that stuff ends up being, but I might be wrong.
Could be.
Also, we both have on the chat, Mary Nabity and I are so excited to hear your voice. So we're watching the chat. If there's any
Hi,
questions,
Mary.
yeah. If there are any questions, feel free to put them on the chat too.
So you see, even if normally we evaluate better the tubular interstitium with the H&E, you see that generally there is some areas with expansion of the interstitium, some inflammatory cells, not very prominent lesions, but still somewhere there are. Most of the tubules are closed together. There's no expansion of the interstitium or significant lesion at that level. But sometimes areas of fibrosis are evident, and we will see better in the trichrome. So I think that sometimes we have these areas of thickening of the Bowman's capsule. But these are pretty much the lesions that we can explore with the PAS. So I'm gonna change with the masking. Okay. At this level, we had no real impression of lesion associated with immunocomplexes. What we do is going through the Massons also to look if we have any evidence of deposits in the, let's see if we have a better look closely. If we have red dots at this level, in the mesangium, maybe it's harder to discriminate, but still, oh, sorry. Still, there are no pink, red dots that suggest us that there is also an immune-mediated or deposits associated with these glomerular lesions. See the areas of sclerosis and synechia that we have in many glomeruli. Check if there's something interesting. I'm gonna go on the glomerulus with the hyalinosis here. So this is the hyalinosis we were looking at before in the PAS that was very, very intense. You see that it is reddish, so it means it's a protein material and not just sclerosis. Otherwise it will be blue. And again, we have the presumed lipid material that stains, it doesn't stain with this staining. Okay, then let's go to the Jones, so PASM.
Yeah, and you guys do a little bit different of a Jones than we do, because you do, right? Like you have a lot more pink in your Jones than we do. I'm not sure why that. I don't know. I know there's a slight difference, because we do. It's usually like it's not as I guess the tubules don't seem as pink on our Jones.
Yeah. Again, we want to go with these staining. We want to go and look at eventual basement membrane remodeling that we don't have actually, or well evident in these stains. Maybe there is a little bit of irregularity here sometimes, but not prominent holes.
If you stay right here, I think that this shows some of the a small issue that we often have as pathologists is you guys can see that kind of black speckling in Bowman space, hopefully.
Mm-mm.
And so sometimes, and it can happen no matter, you know, it happens just every so often you get a little bit of debris from the stain precipitate. So it can, if it lands on the wrong spot, you could misinterpret it as a spike or something like that. So we do kind of we're a little shy if we have a little bit of debris in Bowman space that we kind of, I'm not really sure if it's there, just because that it could just be an artifact, I guess is what I'm trying to say.
And Rachel, oh, sorry, I was just,
Mary, you can speak now.
I was going to ask if the irregularity of staining, it seems like some of the capillary loops aren't staining very well. Is that also just kind of something you sometimes see?
Yeah, I mean, I would say this is the hardest stain for labs to do consistently, in my opinion. And Sylvia, I mean, I know you work with your own lab, but this is the stain I have to send back the most and say repeat. If it's and so what we would do and what I would do in this situation is go to areas where I know there's dark staining and evaluate that capillary loop. And as opposed to the ones that are just not staining because of you know, it's just silver precipitate, right? And it binds to certain things, and sometimes it's just not as strong.
Yeah, it's a very complicated staining. It depends on the days and the operator. I mean, there's no and also you have to incubate for a different time according to whatever we don't know. So it's really depend on the technicians and the ability of recognize the color of the liquid in which the stains is. It's very complicated. I think here it's not the purpose on the stain in this moment, but I think it's very nice to look at those podocytes. Very prominent.
Yeah, they're not happy.
Not at all. Here maybe, but yeah, as Rachel said, it's better to go on the areas that are something that you want to compare with different stains. And go and look for those areas that are convincing maybe or weird in the PAS, and then you go in a specific way on the PASM.
A more interesting question, really. I mean, the Jones silver is an art form in the lab and getting it right. But and so sometimes they're too dark and sometimes they're too light, and there are people that incubate them a bit and look at them and incubate them some more. And I once had a conversation with Agnes Fogo about doing it, and she said, just call my lab. She doesn't know. But my thought is whether or not within a single glomerulus that there's any reason to maybe think of implications of the differences in staining quality with the silver in adjacent capillary loops within the same glomerulus. You think there's any meaning to them being well stained in one and a micron or two, you know, nearby it's not well stained?
I don't know.
Yeah, I don't know either. I think it's a mystery. But yeah,
Yep.
I would say this is the one stain that keeps a lot of labs from being able to routinely and quickly diagnose glomerular disease. And so some labs just don't want to do it. So we're lucky here. I know Sylvia's lucky. I was lucky at with the group at Texas A&M to have a lab that really worked on this stain. So
let me share
also
brief...
everybody, this is Dr. Lee's. I know I have some pathology residents on here that are my pathology residents. He is my hero. So he's the reason that I'm a kidney pathologist. I just want everybody to hear his voice.
One of the people that was part of the talk, that the first time we ever met together as a veterinary group talk about doing all this was at the veterinary school in the Netherlands, and the veterinary school is there with a medical school. And one of their nephropathologists was sort of part of getting this off the ground and whatnot. And once when I was there to visit Astrid, I went to the renal path rounds at the medical school there, and set in on a multi-headed scope. It wasn't electronic. Everybody looked, dozen people. The only slide they showed and discussed for any of the several cases in that hour-long session was the Jones. I sat there and just shook my head. Oh, wow. This is remarkable from my perspective. It was very early on, but it does indicate that people do rely on it. Some people who are depend on it, really rely on it as being very useful.
Yeah. And I just stopped here to show you again the hyalinosis, that again, it's proteinaceous material and not collagen. Otherwise, we will have black stain in this case. Okay, so if we want to look at the last H&E and see if the material of the lipidosis had also the yeah, well, it doesn't seem that we have. And do you understand why nephropathologists doesn't like these stains very much when we are talking about kidney?
What's that stuff right there? Is that just fibrin, Sylvia,
well,
right in the middle, or is that collagen?
Yeah, I think it's just an area of maybe of traction or something of the tissue. Maybe there's some fibrin also.
I think that this is actually like kind of in this field where you're looking, I think some inexperienced pathologists who don't look at a lot of kidneys would see this kind of pink material in the mesangium, and they would, I mean, I wouldn't be surprised if somebody saw this kind of pink amorphous material and called this amyloid. Because we have a lot of training in pathology. I don't think Sylvia and I would have gone there, but some of that amorphous kind of pink stuff, if they only have an HE to look at, might have thought, okay, well, there's some glomerulolipidosis, but there's also some amyloid in there, and hopefully they would have done a Conga red, because amyloid has a much different prognosis. But.
Well, I think it's very clear that with these stains, there are many things that you can't tell,
exactly,
compared to what we could do if we have a more complete panel. And in this case also, lesions are very severe, and you can tell there are synechia, you can tell there are significant lesions, sclerosis, blah, blah, blah. But in less prominent lesions or case in which lesions are very subtle, you could not tell if the kidney has something wrong. It's something that we generally discuss. Stainings are essential to detect and be more sensitive in descriptive lesions.
And I think lastly, are you going to doing EM next, or are you going to do IF?
I don't have IF here.
Just the EM.
I don't have pictures. I just want to show the
oil rido.
No.
I think also, I hope everybody can see just how enormous these glomeruli. They're huge. So these guys aren't just, scarred and small, getting smaller because they're scarring down. They're just enormous glomeruli.
Do you see this screen now with the red oil? Okay, so just a couple of pictures, because I don't have the entire slide, that you see that the material is reddish and consistent with lipid.
Yeah, for the clinicians, this is a specific type of stain that stains lipid. We can do this one, which is called oil red O, or we can do a Sudan black. We are very fortunate because we have frozen samples usually that are submitted to us in the Michelles, and so they don't go through the tissue processing that the paraffin block would. So when we do this stain, and whenever we've shown the stain, we basically take that frozen block and we do the oil red O on the frozen block, and that's why the tubules look a little distorted because of that.
And the
And
architecture is less evident compared to.
yeah, exactly. So you get a little bit of like compression. You can't really see, but you can tell those were glomeruli. So we can do that. If we, it's a little more, you cannot do this stain on processed tissue because the tissue processor actually takes away the lipid from the tissue. That's one of the steps of tissue processing. So we can't do it on a paraffin block. You have to actually have tissue that has never been processed. And before everybody joined, Dr. Benali and I were talking about, I have a current case that I'm working on that I only have formalin fixed tissue. I don't have this type of frozen tissue. And I'm suspicious that this material is here and there's a lot of lipid, but the stain is more difficult, or it's just harder to see the counter stain. So be aware there's a few extra things that we can do with that Michelle's sample that you guys submit to us. We can do this and we can clearly identify that lipid is in there. And also, before you go on, we do have a question from Dr. Vaden about the body condition score of this patient, and this patient was pretty thin. And I don't know, did you guys ever do a lipid profile on this patient as well, or do we know cholesterol or serum lipids or anything like that, triglycerides?
So her cholesterol and triglycerides were in normal range. They were not high.
Oh, wow. That's kind of cool. So yeah, that, I mean, we kind of wonder if these patients are dyslipidemic and that's why they get really bad lipidosis, but.
Yeah, that was when I saw the case and sent a preliminary report with just the histo findings. Okay, so Rachel, do you discuss the electron microscope pictures that I sent you that I selected?
Yes. Let me pull, do you want me to pull them up?
Yeah, please.
I will do that. Let's see. Okay. Are they the ones that start with 718?
Yeah.
Okay.
Yeah, it's just a selection of few images, not to waste too much time on it.
Okay, I'm trying to do it so that it doesn't try to open up Photoshop because that takes forever. Okay, here we go. Let's see. I want to do that. Open with you. Okay. Share screen. Okay, so hopefully you guys can see some EM images. There's 3 EM images as well. Do you want me to start with a different one or?
No, doesn't matter.
Okay. And just so, and I guess to remind myself of your workflow, do you do histology and then your lab also is doing the immunofluorescence? Is Luca still doing the electron microscopy?
Yeah, we send the sample for the electron microscopy in a lab where we are trained the technician in taking pictures of the glomerulus. That's why we always have like 50, 70 pictures that try to gather all the areas of the glomerulus, and then we go through it, through them, and then make the diagnosis. Generally, Luca is taking care more of the EM. Okay. I take care of the IF, and histo is depending on the situation. Okay. Yeah.
So here, I mean, I think we're looking at, and I'm not sure if you guys can see my arrow. Maybe you can.
Yeah.
Okay, so we have a cell here. Here's our nucleus, and here's probably the outline of the cell. We're at the base, probably of a capillary loop, a glomerular capillary loop. I would assume this is an endothelial cell. And within this cell, we have, so we're, kind of at the base, the mesangial base, we have these variably gray to electron lucent. So they might be electron lucent. Sometimes lipid gets to do whatever it wants, is what I've learned through EM. It can be lucent, it can be kind of slightly gray, it can be even dark. It just depends on how much osmium binds to the lipid during the processing step. And I think some of that is dependent on the types of lipid, and maybe even sometimes whether or not they're lipoproteins as opposed to just pure lipid. So I don't get surprised when I see a wide variety of gray to black for lipid. Yeah. And so we have vacuoles here. This is probably within the confines of another cell. And you can even see some of them are even smaller, little electron densities within these large vacuoles. And then let's see, next we have, so now we're looking, and do you want me to do this, Sylvia, or do you want to talk about it?
No, it's okay. Let's, if it is okay for you.
Yeah, because I have the cursor and stuff too. So. So we have two capillary loops here. So we have one capillary loop that's going up towards the top of the picture. We have the endothelial cell with the endothelial cell nuclei. This guy's probably in circulation, or he might be another endothelial cell. It's kind of hard to tell. But that's one glomerular basement membrane. And then this guy is basically, think about it, he's coming towards us. So he's coming from the back of the computer screen out towards us. So that's why we get to see his entire circular glomerular basement membrane. And his endothelial nucleus is unidentifiable, but you can still see a little bit of cytoplasm, and that's endothelial cytoplasm. And we talked last month about how that's a fenestrated endothelium. So we know we have endothelial cells, we know we have a glomerular basement membrane, and then these are the things that are kind of exciting, which makes this a very a surprising case, I guess. So we've got these electron dense material, and they're in this capillary loop. Here's probably another one, and I know they're in the other picture as well. Here's a little electron dense deposit as well. And so that's present. You have remodeling of the glomerular basement membrane around these deposits. So if you guys were here last month, we talked about a pretty early membranous. And so that means the deposit was there, and we weren't seeing a lot of remodeling and encircling of the deposit, whereas in this particular case, these deposits have been here a little bit longer. And so the basement membrane itself is kind of growing up around the deposits. And I know I always apologize every single time I do this. I make this into a story, and I personify the various cells in the glomerular basement membrane. So I understand it's not really growing, but I'm just going to continue to teach the way I teach. So hey, deal with it. Okay. So then there's a podocyte here, and the podocyte should have really good foot processes. Maybe that would be the most normal foot process down here in the entire picture, but you can see nowhere else are foot processes available, and they're not present as well, because the podocyte is the one that is pretty upset by the fact that there's deposits there. And I'm assuming this is probably Bowman's capsule here, and this is probably parietal epithelium.
Yep.
And then, oh, this is a great one. So this is, again, showing those surprise immune complex deposits. There's really nothing else that could be. This was probably an older deposit. You can actually see there's a little bit of electron dense material still left. And then there's this kind of electron lucent halo. And so in human medicine, and we have seen also in dogs, that these deposits, after they sit there for a while, can actually go away. We use the word reabsorption. I don't know if anything actually technically absorbs them or if they dissolve, I'm not sure, but they can go away. And then you're kind of left with this electron lucent halo, whereas the glomerular basement membrane material that was created or developed and grew around the deposit, it actually ends up staying there. So you see this kind of what we call a hole. So it's like there was a deposit here, it disappeared, and now we have this hole within the glomerular basement membrane. Podocyte is still very upset with lots of fused foot processes. Here's podocyte cytoplasm here, and here is podocyte nucleus here up at the top, and this is another capillary. So it was an interesting case because we see glomerulolipidosis as a lesion, and we've even published it as well as being a process. And then in some of those cases that we published in VetPath, they did have immune deposits. So it's not impossible to have, but you know, this was kind of a surprise, since like what was mostly happening on histology was just this marked glomerulomegaly, marked glomerulopidosis, and then we had these surprise immune deposits here. I think that's the last picture.
Yeah.
So I'm going to stop sharing that. And I'm not sure, let's see, I will pull up, actually, I will share one more thing. I'll pull up your interpretation. I haven't read it yet, so I apologize if it's.
And just to complete the thing, we run the IF. I just don't have pictures. We had, some stainings, but it was more yellowy to reddish, consistent with an autofluorescence of the lipids. And that could possibly also mask an eventual real stainings due to deposits, possibly. That's my interpretation of what we saw after the electron microscope.
Yeah, I agree. It can definitely when we've seen the combo of lipidosis and immune complex staining, it's very difficult to say which is which. Now, I think it's easier, and I'm sure you'll agree, I hope you'll agree with me, Sylvia. There's been cases where ICGN was like the predominant lesion, and then you might have one glomerulus with lipidosis. So like ICGN's the dominant thing, and only one glomerulus has, you know, a segmental lipidosis, and that's much easier to differentiate, because as you're looking at on IF, every single glomerulus has granular staining, and then there's that one that's kind of blowing apart with the lipid. So
yeah, exactly.
And so, yeah, it's difficult to, you know, this is one of those ones where TEM was required. This diagnosis would have been missed if it didn't get performed. And then again, I don't know, does that change? Does that change how things get treated or managed? And I guess we'll leave that. I don't know what you guys are doing with the case currently.
So after we got the final report, we did decide to start her on immunosuppression because she wasn't improving at all with like the standard protein losing nephropathy therapy. And I mean, her proteinuria did not improve much, and her creatinine is increasing. So we started her on mycophenolate, I think 2 weeks ago, and we still haven't seen her since. She's supposed to be coming in for a checkup, I guess, in the next couple of weeks.
And then I guess from the clinician standpoint, what's your time frame for expecting response to immunosuppressive therapy? And there's lots of clinicians that can comment.
Yeah, so we decided to wait about 3 to 4 weeks before our first evaluation, but I'll be happy to hear other people's experience and ideas.
Hi, this is Gilad. What we had, so I don't think we have enough good evidence to actually come up with a good recommendation. But actually, when we did the glomerular consensus statement a few years back, we suggested that immunosuppression would take some time to take effect, and then there should be some resolution of the pathological changes before we see any improvement. And so what we had suggested back then is that you have to, before you say or suggest that immunosuppression is not really working, you have to give relatively rapidly acting medications at least 8 weeks. And if you are using more slowly acting medications like azathioprine, you actually need to wait 12 weeks before you give up, switch medications, or say this is actually not working. But this is not really based on solid evidence. So at least this is what we are suggesting based on current evidence that we have.
Any anecdotal stuff from the other internists that see a lot of glomerulonephritis cases?
I'd say you rarely will see those cases that respond very quickly. Within the first like maybe 2 to 4 weeks, they'll have a significant reduction in their proteinuria. But typically it's going to be, I would say, at least 4 to 8 weeks that you're hoping to see some response and some clinical improvement. And if I see a trend at that point, I'm pretty happy and I'll continue. If I don't see anything by probably the 2 to 3 month mark, then that's where I'm probably going to think about considering changing my immunosuppressant protocol. But it can be very variable. I think we get these patients at various points of their disease, and the more acute they are, potentially the faster they might turn around, but that doesn't always tend to be the case.
I would say from the RVC that our experience is just that patients, I don't know, for whatever reason, our patients don't seem to tolerate mycophenolate very well. And we just get a very high prevalence of GI side effects, and why we should have those issues when other people seem to not have such a problem. I'm not sure, but it's not, I mean, that's not specific to glomerular disease. That also follows with other immune mediated diseases. It's not logical. I can't explain why that is, but lots of our patients don't seem to tolerate it.
Is it dose?
Which dose are you using?
Yeah, because usually if we use a lot of the published doses, we'll get diarrhea, but we go a lower dose, at least to start.
But like lower, like 10 mg per kg.
Honestly,
Yeah,
I look it up, but I think that's
the first one in our service, at least, that started to use mycophenolate for neurological diseases, they started with a 20 milligram per kilogram dose, and they went back to their data and show, and actually they published that around 25% of the cases will have severe clinical signs when you use these kind of high
but
doses.
it's supposed to be better down at sort of like 10 mg per kg, but I guess our experience, and I guess it's one of those things because everybody's sort of heard of the bad experience, maybe it doesn't get used all that much, but then but even at the lower dose, so in that paper, sort of the dose at which they didn't see such an incidence of side effects, I don't know, we still seem to see problems with it.
Well, in people, it's been shown it's actually an inactive metabolite. So it's not something that causes immunosuppressive effects of mycophenolate that accumulates when you have renal disease. And I think it certainly accumulates when you have decreased GFR, but maybe a little less so when it's just proteinuria and GFR is maintained. And that's the main trigger for the GI intolerance that's seen in people. And so for personally, my normal dose of mycophenolate, I do 10 mg per kg twice a day. If they are azotemic, then I treat them at 5 mg per kg, and I will actually start them on once a day for probably the first 3 to 5 days to see if we can start just developing a bit of tolerance on the patient before going up to twice a day. But if they're azotemic, I'll lead them at 5 mg per kg twice a day as my target dosage. But I would agree. I think that the patients with renal disease might not tolerate it well. I think they tolerate it better than like the I think the IMHA patients and the other immune-mediated diseases that we use mycophenolate, in my experience, they tolerate it better than the GN patients. They seem to have the highest frequency of GI side effects in the patients that I see. But those IMHA patients, I'm routinely using 10 mg per kg twice a day, as long as their renal function is normal.
Yeah, we don't tend to use it very much for IMHA. I mean, there's a big cost differential using mycophenolate versus azathioprine. So just on a practical logistics thing, and you know, most patients will get prednisone azathioprine for IMHA and things. But I guess usually we've used the 10 mg per kg BID. Certainly not the 20 mg per kg, but it's interesting to hear that you go at 5. But I mean, I always get a bit frustrated with the immunosuppressives because I think it's just it's so non-evidence based, and so difficult to know actually what you're doing to the immune system, and even some of the things that we say about mycophenolate being working faster than azathioprine and things, when you actually try and find evidence to substantiate that, it's pretty scant.
I agree. And I think what from the beginning, and George probably can speak to this too, that when we were working with this renal biopsy service and we were collecting all of these cases, we had written and submitted, Dr. Cowgill, Polzin, and the IVRPS was associated with it too, a couple of Morris Animal Foundation grants trying to do, placebo-controlled, double-blinded studies, blah, 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 blah. And I would evaluate the pathology, but it really was difficult to fund it because we were trying to recommend invasive biopsy procedures in patients that had returned, quote unquote, to normal as repeat samples. Plus it's expensive, right? So it was, our feedback was, well, if you give them medication and then their proteinuria resolves, what's your justification for going back and getting more tissue in a healthy dog, or quote unquote, serologically, biochemically, whatever healthy. So, we've tried to do the correct way to prove that this is effective. And we've written grant proposals to be based on that. It's just really hard to get them funded.
Yeah.
So I guess when you guys bring this patient back, would you guys mind sending me an email and I can forward it to everybody about any updates for this case? Is that cool?
Sure. I love
Awesome.
that.
And speaking of updates, I'm glad that Dr. Foster is still here. I think he is. And I just wondered, so I'm going to share quickly what we talked about last month was a Cocker Spaniel that had pretty proteinuria, was biopsied from proteinuria, and it did seem to be that there was a immune complex component, which we went through a lot last time, and we weren't really sure, because based on the histology, I couldn't even definitively say whether I thought there were immune complexes. Dr. McLeland, who is my associate pathologist here at IVRPS, was able to look at the TEM and prove that the deposits were there. So a little bit of a similar situation, although this current dog here, this Cocker Spaniel, didn't have all of that glomerulolipidosis. JD, how's this dog doing? This is Finn.
Finn is doing clinically well. We did start her on mycophenolate based upon the findings of the immune complexes, and I think actually had a worse time tolerating the telmisartan that we started. Had bad diarrhea after we started the telmisartan, and actually paused that, kept her going on the mycophenolate, and then lately we've been trying to institute the telmisartan therapy for her. But clinically, she's doing very well. I have one set of recheck values on her at the end of last month. She's due to get her blood work checked and urine checked either at the end of this week or maybe beginning of next week. And I would say overall things were fairly static from the time that we had submitted, checked things before the biopsy. Her SDMA went from 24 to 17. Her BUN went from 52 to 40. Her creatinine needed to go from 1.6 to 2.1. So a little bit of a mixed pattern for overall her kidney values. Her albumin, though, did go from 1.4 up to 2.0. And her UPC was 5.9, and then recheck was 5.3. So, she seemed like she was clinically doing well, that this was not when she was having the diarrhea, so I don't think that she was volume contracted for the albumin to go up. We haven't seen a significant improvement yet in the UPC, but she's feeling well, she's tolerating the mycophenolate, and that was only about a month into treatment. So we just decided to stay the course, try to see if we could get her on the telmisartan again from the time of this last blood work. And then she's due to get it checked sometime, like I said, in the next week or two. If not this week, next week, we're supposed to get some recheck lab work on her.
That's great. I think, go ahead.
With regard to prognosis and response to therapy, I would like to add that I think that I don't want people to think that that I believe that you can measure prognosis by the structural changes. On the other hand, I don't think they are irrelevant. The more abnormal the structures are that have long turnover times, like basement membrane material, interstitial fibrosis, and those sorts of things, even if you are successful in modulating the pathogenic mechanism with medications or other strategies, you're faced with the consequences of the either irreversible or slow to reverse changes that matter to the function of the kidney. And you have to keep that in mind. The other thing, though, that there are lesions that can change quite a bit are the cellularity. And so I'd expect hypercellularity and changes that go with the cellular components of the pathologic process to be more readily abatable, if you will. And there are examples, for instance, in human medicine, that, there's a post-infectious glomerulonephritis, which is largely just a cellular response. And it's my understanding, and Rachel, that having worked with physician nephropathologists, I think that's considered to be a fairly reversible form of glomerulonephritis. And going back to the veterinary experiences, some of our best outcomes have been, and it goes back to even one of the first dogs that we, within the first couple of years of the UC Davis case, was a dog with early membranous, profound proteinuria, but and lots of, subepithelial immune complex deposits with little GBM remodeling. And that dog within a year had UPC that was in the normal range on immunosuppressive therapy. So again, I don't think you can actually measure the prognosis on structural changes very precisely, but they're not irrelevant.
I agree. I think I think cellularity can and will go away. Even crescents, which I wasn't entirely sure when I was looking at this, first of all, whether or not this part right here was a crescent. Crescents will scar down. They'll make little fibrosis areas within Bowman space. So a lot of that stuff can go away, whereas the changes like sclerosis and podocyte loss are what we consider based on what we know from nephropathology and other species. Like this glomerulus isn't filtering anything. And if a lot of the glomeruli look like this in this dog, it's going to be really hard to regain and recover a lot of significant renal function. So I think that's kind of our perspective. And that's why a pathologist looks at every single glomerulus as when we get a kidney biopsy. Now, it's really hard for us to look at every single glomerulus when we have an autopsy sample, but we do get, when I have an autopsy sample, I count 100 glomeruli and see how many of them look like this, how many are globally sclerotic, just to get a somewhat good estimate of that. So we try our best.
And don't forget the tubular interstitial compartment.
Yeah.
It's been 30 plus years ago, but there was a period of time when there were a number of studies in human medicine that looked at correlations between morphologic changes, or in renal diseases and function, and sort of across the spectrum of different kinds of glomerular disease, whether it be diabetic nephropathy or membranous or these kinds of things. The biggest correlation to renal function was extent of chronic tubular interstitial injury, and so tubular interstitial compartment's status in any disease, and it sort of was regardless again of the inciting glomerular disease. It was the tubular interstitial compartment that told the tale of functional status.
Oh, do any of the participants, we're kind of nearing the last 5 minutes. Does anybody have additional questions or comments?
So I wanted to say one more thing about the mycophenolate, that if you look back on it historically, the reason that we chose mycophenolate, or that many of us are using mycophenolate, wasn't based on evidence, but it was with the idea that if we were all doing the same thing, we could gather more evidence. And I don't think anybody's ever gone, well, I know nobody's ever gone through to try to collect those cases just to see mycophenolate versus no immunosuppression, how they do. But again, that was the intent, was just if we were all using the same drug, then perhaps we could go back retrospectively and pull the data together and see if immunosuppression in general made a difference, which of course we all believe it does.
I mean, the data's there. I just would love to have I don't know, a grad student or a master student attack the information, because we have been, and I should mention that I've said this a lot of times when I speak at meetings, we get a lot of follow-up data from cases. We contact some clinicians. We have some clinicians we work very closely with that give us a lot of follow-up data. And my technician, who was, when we were kicked out of the lab because of COVID and we weren't allowed to really do anything except for work from home, he's been, collecting and putting in as much of the ClinPath data, ultrasound results, all of those things. So the Visions database expanded exponentially via teleworking. We still have a lot to put in, but the material exists. It's just that neither Dr. Hokamp, myself, or Mary Nabity have time to gather it, to publish it. And so, and I know the clinical group was working on it. We've kind of also been distracted by other important topics like the nephropathology and sorry, not nephropathology, but nephrology and urology discussion. But we have the data. It's just, it's impossible for us to kind of go through and say these are all the cases that were treated with mycophenolate. They did say, and I think that when we did publish a paper looking at glomerular disease in dogs from the UK, and the dogs of the subset of the dogs that have immune complex disease, and actually it's less common to have immune complex disease in the UK than it is in the United States. But the dogs that did have immune complex disease, the ones that got any type of immunosuppression, did much better than the immune complex dogs that got no immunosuppression. So it wasn't specific to mycophenolate, though. I think they also had a couple dogs with azathioprine on board. So, I mean, at least we're kind of putting into the literature that it's working to immunosuppress them. But I think Shelley's point about if everybody did the same thing, we would gather enough data to work on this. So. Any of you aspiring medical internal medicine residents want to just start to dig in and get that data, we're happy to work with you. Okay, it's at the end. And hopefully we will be able to do this again and resume next month. I'm really glad that everybody was able to participate. And thank you, JD, for the follow-up. And hopefully we'll get some follow-up next month about this current patient that we just discussed. So thanks, guys.
Thank you. Bye-bye.
Thanks. I'm so glad to hear you, Sylvia. I miss you so much. Okay, stay safe and stay healthy, and I want lots of updates, okay?
Yeah, sure. Okay. It was nice to hear you.
See ya. Bye.
Bye.
Bye, Sylvia.
Hello, everyone.